Welcome back to Deep Dive Ortho. Today we're really getting into something fascinating, the world of overhead sports.
Absolutely. Think, that incredible power in a baseball pitch, or the sheer grace and precision of a tennis serve, or a volleyball spike.
Exhilarating stuff, but also the injuries, right? That's the flip side we see all too often in clinic. The shoulder, the elbow.
Exactly.
Yeah.
And that's our focus today, specifically for you, our listeners, the medical professionals, the physios, the surgeons, dealing with these athletes day in, day out.
Yeah, we want to move beyond just the surface level and give you the practical, evidence-based insights you can actually use to diagnose, manage, maybe even prevent these injuries.
Precisely. Our mission today is a proper deep dive into what we often call the sporting shoulder. We'll cover the biomechanics, the key risk factors, and the latest thinking on rehabilitation, all to help you guide your patients back to their peak performance.
A crucial mission. So let's start basic. What actually is an overhead athlete in clinical terms? What makes them so prone to these issues?
Good starting point. Essentially, it's anyone whose sport involves repeated, often explosive high-energy movements above the head.
Like throwing, spiking, serving.
Exactly. Actions that really push the shoulder, the glenohumeral joint, often well beyond its normal physiological range, again and again.
Putting huge stress on those structures.
Immense stress, consistently. Think baseball pitchers, obviously, but also American football quarterbacks, tennis players, volleyball players, swimmers are a big group, handball players, cricketers, javelin throwers.
Even water polo. I hadn't considered that one.
Even water polo, yeah. Any sport demanding those intense, repetitive overhead actions creates this unique, high-risk biomechanical environment.
And the prevalence figures really drive home the scale of the problem, don't they? Especially, say, in baseball.
Oh, absolutely. Baseball is, well, notorious for it. You're looking at figures like, 58 to 69% of all reported injuries affecting the dominant upper extremity.
That's huge. Almost defines the sport in some ways.
It does. And for pitchers in high school baseball specifically, it accounts for a remarkable 74% of shoulder injuries. A massive contributor.
Wow. But it's not just baseball, is it? You mentioned others.
No, not at all. Cricket sees significant numbers, 23 to 36% of high-level players reporting shoulder pain in a single season. Handball, we see an incidence somewhere between 7 and 28% in elite players.
And quarterbacks in American football.
Yep. Shoulder issues make up about 15% of all their injuries, and around 2% are directly linked to overuse from throwing. So yes, it's a widespread challenge across many different sports.
And the impact for the athlete themselves, it goes way beyond just the initial pain, doesn't it? Clinically, we see the fallout.
Oh, definitely. The consequences are substantial. Performance drops, obviously, weeks, sometimes months, sidelined. Then there's the often demanding rehab process, or even the need for surgery.
And potentially career-ending in some serious cases.
Sadly, yes, that can be the reality. Which leads us to this really interesting and fundamental concept for managing these athletes, what's known as the thrower's paradox.
The thrower's paradox. Okay, unpack that for us. It sounds key to understanding the underlying issue.
It really is. It's this inherent conflict, almost a contradiction, in the shoulder's demands for high performance. You need huge amounts of flexibility specifically, extreme external rotation to generate power and velocity for throwing.
We're talking extreme range of motion here, right?
Extreme. The glenohumeral joint can reach 165, maybe 175 degrees of external rotation during that late cocking phase of a throw. It's quite remarkable. But, and this is the paradox, you also need sufficient inherent stability, rock-solid stability.
To stop the humeral head subluxing or dislocating?
Precisely. To prevent instability events when all that force is going through the joint. So you need extraordinary mobility and robust stability simultaneously.
So it's balancing those two opposing demands, both pushed to their absolute limits.
Exactly that. Finding and maintaining that delicate balance is absolutely critical for injury prevention. And it's this balance that's so easily disrupted by the repetitive high forces involved in overhead sports.
Like walking a physiological tightrope. Okay, that makes a lot of sense. So having set the scene with the burden and this core paradox, let's dive into the mechanics. The intricate biomechanics of throwing. We often hear the term kinetic chain. What exactly does that mean in this context?
Well, the kinetic chain is fundamental here. You really need to grasp it to understand the injuries. It describes how the body segments are interconnected and work in a very specific sequential order to transfer energy during movement.
So it's not just the arm doing the work.
Not even close. In overhead throwing, think baseball again, over 50%, more than half of the kinetic energy generated for that throw actually comes from the legs and the core. It's transferred up the chain to the upper extremity.
Right, like a whip effect, starting from the ground.
Spot on. It's this sequential, efficient transfer of energy, starting from the ground up, that generates the huge forces and velocities we see. If any part of that chain, any link, is weak or out of sync,
Then the whole system breaks down.
or becomes inefficient. And that's where the trouble starts. Deficits or weak links, maybe in the core muscles, spinal mobility, hip power or rotation, even glenohumeral ROM itself, or how the scapula moves, scapular kinetics, they compromise this energy transfer.
And the result?
Poor energy transfer means increased stress and loading on other parts of the chain, often tissues further up like the shoulder and elbow, that aren't designed to handle that kind of isolated force. That's a primary driver for many injuries we treat.
It sounds like this incredibly fast, complex dance. Could you walk us through the typical phases of a throw? What's happening at each stage?
Certainly. And it happens incredibly quickly, often less than 200 milliseconds for the whole thing.
Yeah.
It typically starts with the stride, the initial movement setting the base. Then immediately, pelvis rotation kicks in, generating power from the lower body.
Okay.
That energy moves up through upper torso rotation. Then we get to the really demanding part, the arm cocking phase, especially late cocking. This is where we see that extreme glenohumeral external rotation we talked about, 165 to 175 degrees.
Putting immense force on the front of the shoulder.
Immense, near maximal tensile forces on the anterior capsule and ligaments. It's really stretching the limits.
That's astonishing. What happens next once the arm is fully loaded?
Right after late cocking comes the arm acceleration phase. This is explosive. Rapid elbow extension combined with incredibly fast shoulder internal rotation.
How fast are we talking?
Peak velocities can exceed 7,000 degrees per second for internal rotation. It's phenomenal speed, generating the final velocity for the ball, or javelin, or whatever is being propelled. This leads directly to ball release.
The moment of truth.
Exactly. But crucially, the motion isn't finished. We then enter the arm deceleration phase. And physiologically, this might be the most demanding phase.
Why is that? Slowing down sounds easier than speeding up.
You'd think so, but the body has to dissipate those incredibly high velocities over a tiny fraction of a second. The distractive forces at the shoulder during deceleration forces, essentially trying to pull the arm out of the socket, can actually equal the thrower's entire body weight.
Wow, equivalent to their body weight pulling the arm away. How does the body even cope with that? What's happening mechanically?
It's a highly coordinated effort. The rotator cuff muscles fire eccentrically, working like brakes. The scapula plays a huge role too, continuing to tilt anteriorly, internally rotating and downwardly rotating, while the humerus adducts horizontally and internally rotates. It's this complex interplay that absorbs and redirects those massive forces.
A controlled crash landing for the arm.
In essence, yes. And it's also worth mentioning, particularly for you dealing with younger athletes, in skeletally immature individuals, say 11 to 16-year-olds, these repetitive forces, especially the external rotation torque, can actually cause physical damage at the proximal humerus. Leads to what we call little league shoulder.
Proximal humeral epiphysiolysis.
Right.
So the developing skeleton is particularly vulnerable.
Extremely. It highlights how these forces impact different age groups. And finally, after deceleration, there's the follow-through, completing the motion and allowing further dissipation of energy across the entire body.
So the ideal is this perfectly timed sequence. What happens when it breaks down? Biomechanical flaws, fatigue setting in.
That's when problems arise. If the sequential timing, the coordination of muscle firing is compromised, you get abnormal loading stresses on tissues that aren't accustomed to it. An efficient kinetic chain needs everything working in harmony.
And if it's not, if there's stiffness, weakness, poor endurance,
Then the mechanical load shifts. Things like poor muscle flexibility, maybe reduced muscle endurance as a game progresses, limited shoulder or hip range of motion, poor spinal mobility, or just general weakness, especially in the rotator cuff or core, disrupts that smooth flow.
And I guess that's where this catch-up phenomenon you mentioned earlier comes in, the body trying to compensate.
Exactly. The catch-up phenomenon describes how a breakdown further down the chain in the legs, hips, core, spine forces the segments further up, like the shoulder and elbow, to work harder, to generate more force or velocity to compensate.
Trying to make up for the lost energy transfer.
Precisely. We see it in fatigue pitchers, for example. They might show less shoulder external rotation, but maybe more knee flexion in their lead leg. These subtle changes upstream force the shoulder and elbow joints to pick up the slack, absorb forces they aren't designed for in isolation.
Which significantly increases the injury risk right there at the shoulder or elbow.
Massively. And it's critical for us clinically. If you only treat the painful shoulder or elbow without addressing the underlying kinetic chain deficit, you're essentially just treating the symptom, not the root cause. The problem will likely recur.
That really drives home the importance of a full body assessment. Okay, so if the kinetic chain isn't working efficiently, the shoulder and elbow bear the brunt. This leads us perfectly into discussing the common casualties of the specific injuries we see. Let's start with the shoulder. What are the frequent culprits?
Given those biomechanics, several shoulder injuries are unfortunately very common. We often see SLAP tears, superior labrum anterior to posterior tears. These are particularly prevalent with overhead motions like pitching, where traction and compression forces on the labrum are high.
Okay, SLEP tears. What else?
Then there's biceps tendonitis or even tendon tears. The long head of the biceps tendon runs right through the shoulder joint, and repetitive throwing can cause irritation, inflammation, micro tears, or eventually a full tear, often where it attaches to the labrum.
Makes sense. And the rotator cuff. That must be under huge strain.
Absolutely. Rotator cuff tendonitis or tears are incredibly common. These crucial muscles and their tendons are under immense stress during both the high-speed acceleration and the powerful deceleration phases. Overuse leads to inflammation, tendinopathy, partial tears, or full-thickness tears.
Right. And what about impingement? It's a term we hear a lot. Is it a specific type in throwers?
Yes, in overhead athletes, we often talk about internal impingement. This typically happens during that late cocking phase. The posterior rotator cuff tendons, usually the supraspinatus and infraspinatus, get momentarily pinched or compressed between the humeral head and the posterior superior rim of the glenoid socket.
So not the classic subacomial impingement under the acromion.
Not usually, although that can occur too. But internal impingement is more characteristic of the throwing motion itself. This repeated pinching can cause fraying or partial undersurface tears of the cuff tendons and can also damage the adjacent labrum.
It's worth touching on the broader concept of shoulder impingement syndrome, or maybe subacromial pain syndrome, as it's often termed now. There's been some debate around diagnosis and treatment, hasn't there?
There has, yes. Historically, impingement syndrome was a bit of a catch-all. Clinically, you look for things like that painful arc of motion, usually between 60 and 120 degrees of abduction. Causes were thought to range from bony spurs under the acromion to rotator cuff dysfunction or bursal inflammation.
But the thinking on management has evolved,
Yeah.
especially regarding surgery.
Significantly. The current evidence, particularly from high-quality trials, doesn't strongly support subacromial decompression surgery for patients with more than 3 months of shoulder pain without a clear history of trauma. Exercise therapy, physiotherapy, is now generally the recommended first-line treatment.
Why the shit?
The understanding now is that symptoms often relate more to tissue sensitivity, load intolerance, perhaps changes in activity levels, rather than purely a structural blockage that needs surgical removal. Of course, if there's a significant structural issue like a large rotator cuff tear, surgery might be indicated, but not routinely for uncomplicated subacromial pain.
That's a really important clinical point. What other shoulder issues do we commonly see in overhead athletes?
We also frequently encounter instability. This can range from subtle microinstability to frank subluxations or even complete dislocations where the humeral head slips out of the glenoid socket. The repetitive throwing motion can gradually stretch the shoulder capsule and ligaments over time, leading to increased laxity.
Making the joint less stable.
Exactly. And then there's scapular rotation dysfunction or scapular dyskinesis. This refers to alterations in the normal positioning or movement patterns of the scapula, often due to muscle imbalances or fatigue in the stabilizing muscles like the serratus anterior or trapezius. You might see visible winging or abnormal rhythm during arm elevation.
Now, scapular dyskinesis is interesting. I know there's debate. Is it always pathological, or can it sometimes be just an adaptation to the sport?
You've hit on a key nuance for clinicians. It's true, while scapular dyskinesis is often found alongside shoulder pain or injury, studies show scapular asymmetries are also quite common in perfectly healthy, asymptomatic overhead athletes.
So it's not automatically a problem?
Not automatically, no. It makes it tricky to definitively say if it's causing the pain or if it's maybe an effect of the pain or even just a normal adaptation to the extreme demands of their sport. However, obvious dyskinesis, the really marked asymmetrical patterns, especially during arm movement, is still generally considered a risk factor. It suggests underlying muscle imbalance or poor neuromuscular control that probably warrants addressing in a rehab program.
Discerning adaptation from dysfunction.
No.
Okay, and one more for the shoulder. GIRD, glenohumeral internal rotation deficit. Sounds like a direct consequence of throwing.
It often is. GRD is a significant finding, particularly in throwers. It's characterized by a loss of glenohumeral internal rotation range of motion in the throwing arm compared to the non-throwing arm.
What causes that loss of internal rotation?
It's thought to be due to adaptive tightening of the posterior soft tissues. The posterior capsule, the posterior band of the inferior glenohumeral ligament, and the external rotator muscles, often as a result of the repetitive, high-velocity eccentric loading during deceleration, and the extreme external rotation in cocking.
And why is GRE a problem?
Because that loss of internal rotation isn't isolated. It shifts the point of contact and alters the biomechanics within the joint during throwing, increasing the shear forces across the shoulder. This significantly increases the risk for both posterior superior labral tears, like SLA piers, and undersurface rotator cuff tears. Addressing GRD with specific stretching, like the sleeper stretch or crossbody stretch, is often a key part of prevention and rehab.
Understood. Right, let's move down the arm to the elbow. The ulnar collateral ligament injury, the famous Tommy John injury, looms large, especially for pitchers. What makes that specific ligament so vulnerable?
The ulnar collateral ligament, UCL, sits on the medial or inner side of the elbow. Its primary job, specifically the anterior bundle of the UCL, is to resist valgus stress,
Valgus stress being.
a force pushing the forearm outwards, away from the body relative to the upper arm. This creates a gapping or tensile stress on the inside of the elbow joint. During throwing, especially in that late cocking acceleration phase, immense valgus forces are generated across the elbow. The UCL is the main stabilizer against this.
So it's constantly being stretched under high load.
Exactly.
Yeah.
Repeatedly, forcefully stretched, which makes it incredibly susceptible to overload and eventual failure.
And when it does get injured, what does the athlete typically experience? What are the red flags for us?
Often, athletes report sharp pain on the inside of the elbow, usually pinpointed right over the UCL. This pain typically occurs during the acceleration phase of throwing, sometimes during follow-through. A distinct pop or tearing sensation at the time of injury is quite common, though not universal.
Followed by?
Followed by immediate pain, often an inability to continue throwing, effectively loss of velocity, loss of control. Swelling and bruising might appear over the medial elbow. They might also notice some loss of elbow range of motion, or even a feeling of instability in the joint, especially when stressed. If it's a lower grade strain, rest might initially help the pain, but it often returns upon resuming throwing.
And what actually causes the UCL to tear? Is it usually one single traumatic event or more of a gradual process?
That's a really important point. Unlike, say, an ACL tear in football, which is often a single traumatic event, UCL injuries in overhead athletes, particularly pitchers, are rarely caused by one specific incident. It's far more commonly the result of cumulative microtrauma.
Small tears adding up over time.
Exactly. Chronic repetitive strain from intense or repeated valgus stress during throwing leads to microtears that eventually coalesce into a partial or full thickness tear. Several factors contribute. Poor throwing mechanics are huge. Sheer overuse, high pitch counts, throwing too often without adequate rest, high throwing velocities naturally increase the stress, and even certain pitch types, like sliders or curveballs, are thought to place greater valgus load on the elbow.
And does the kinetic chain come into play here too? Can problems elsewhere affect the elbow?
Absolutely critical. Kinetic chain dysfunction is a major contributing factor. If an athlete has poor lower extremity strength, or core instability, or maybe restricted hip rotation.
They can't generate force efficiently from the ground up.
Precisely.
Well,
So they try to compensate by generating more force with their arm, putting excessive strain on the shoulder and elbow, including the UCL. We also often see associations with issues higher up the chain, like GID, limiting shoulder internal rotation, or scapular dyskinesis affecting shoulder stability. These proximal deficits force the elbow to take on even more compensatory load.
it all links back. Given how serious a UCL tear can be for a throwing athlete, what are the treatment options? Where do you start?
Treatment really depends on the severity of the tear, the athlete's level, and their goals. For partial tears or strains, especially in non-elite athletes or those willing to modify activities, non-surgical conservative management is often the first approach.
What does that involve?
It starts with the basics: rice rest, ice, compression, elevation to manage the acute symptoms. NSAIDs can help with pain and inflammation. The core of non-operative treatment is then a structured physiotherapy program
Focused on
strengthening the muscles around the elbow joint, the flexor pronator mass medially, the forearm muscles, the biceps and triceps to provide dynamic stability. Improving kinetic chain efficiency is also key, addressing any deficits in the legs, hips, core, or shoulder mechanics. The goal is to offload the healing ligament and allow it to repair, whilst optimizing the mechanics to prevent re-injury. Exercises might include things like biceps curls, forearm pronation supination, wrist curls, grip strengthening, usually starting with low resistance and moderate reps and gradually progressing.
And if conservative management isn't enough, or for a complete tear in a high-level thrower?
Then surgical reconstruction becomes the primary option. This is the famous Tommy John surgery.
Named after the pitcher, of course, what does the surgery actually entail?
It's a ligament reconstruction, not a repair. The damaged UCL is replaced with a tendon graft. This is usually an autograft, taken from the athlete's own body, commonly the palmaris longus tendon from the forearm if they have one, or perhaps a hamstring tendon or part of the toe extensor tendon. Sometimes an allograft from a deceased donor is used.
And how is the graft secured?
The surgeon drills tunnels into the humerus and the ulna at the points where the native UCL attached. A tendon graft is then threaded through these tunnels, often in a figure-of-8 pattern, and secured under tension to recreate the stabilizing function of the original ligament.
Sounds complex, and the recovery must be significant afterwards.
It is indeed. The rehabilitation after Tommy John surgery is a very long and demanding process. We're generally talking 12 to 15 months, sometimes even longer, before an athlete can expect to return to competitive throwing at their previous level.
A year or more out of action, why does it take so long?
It's biology. The grafted tendon needs time to undergo a process called ligamentization. It needs to develop a new blood supply and gradually transform its structure and properties to resemble those of a native ligament. This is a slow biological process that simply can't be rushed.
And the rehab program itself?
It's highly structured and phased. It starts very gently, protecting the graft while gradually restoring elbow range of motion. Then it progresses through strengthening exercises, not just for the elbow, but crucially for the entire kinetic chain. Scapular stability, core strength, lower body mechanics. There's a strong emphasis on restoring normal scapulohumeral rhythm. Finally, there's a very gradual interval throwing program, meticulously increasing volume and intensity over many months. It requires immense patience and dedication from the athlete.
You mentioned earlier a false perception about this surgery, almost like some athletes thought it was a performance enhancer. Could you elaborate on that? It seems counterintuitive.
Yes, it was a concerning trend observed maybe 10, 15 years ago. There seemed to be a perception among some athletes, perhaps fueled by media stories of pitchers returning successfully, that Tommy John surgery somehow made the elbow stronger than before, potentially even increasing throwing velocity.
So some might have sought it out even without a definite tear.
There were anecdotal reports suggesting that some athletes might exaggerate symptoms or seek out surgery, hoping for this perceived enhancement. It became really important for us as physicians, surgeons, and therapists to actively counter this misinformation.
How so?
By clearly educating athletes, coaches, parents, and the public that Tommy John surgery is indicated only for significant, functionally limiting UCL tears confirmed by clinical examination and imaging, usually MRI. It's not a performance-enhancing procedure. If the ligament isn't significantly torn, the surgery offers no benefit and carries unnecessary risks.
And for those managed non-operatively, what's the success rate like?
Actually, it's pretty good for appropriate candidates. Studies suggest that around 80% of athletes treated non-operatively for UCL injuries can return to overall sports participation, and about 78% manage to return to their previous level of play. Sometimes this involves physiotherapy alone, sometimes combined with orthobiologic treatments like platelet-rich plasma PRP injections, although the evidence for PRP here is still evolving. But it highlights that surgery isn't always necessary.
That's vital context for managing expectations. Okay, we've covered the what and how of these injuries in detail. Let's shift focus now to unpacking the why. What does the research, particularly systematic reviews, tell us are the most critical risk factors we should be aware of?
This is absolutely key for prevention and screening. Starting with range of motion, ROM, the evidence is actually quite nuanced. Systematic reviews suggest that looking at just absolute shoulder ROM values or simple side-to-side differences in total ROM isn't consistently predictive of injury across all overhead athletes.
Oh, interesting. So measuring ROM isn't always that helpful.
Not quite. There's crucial specificity. For example, in professional baseball pitchers, a very specific finding is highly predictive. If their throwing arm external rotation isn't at least 5 degrees greater than their non-throwing arm, they're twice as likely to get injured during the season and 4 times more likely to eventually need shoulder surgery.
So it's about maintaining that throwing-specific adaptation of increased external rotation.
Exactly. Losing that relative external rotation, or having what we call a total arc of motion deficit, is a big red flag in that specific group. For swimmers, there's some limited evidence that either very low, less than 93 degrees, or very high, more than 100 degrees, external rotation might increase risk. And as we discussed before, GRRD, that loss of internal rotation due to posterior tightness, remains a consistently identified risk factor across many overhead sports because of how it alters joint mechanics.
Okay, so specific ROM deficits matter, particularly GRD and loss of relative external rotation in throwers. What about strength? Where do weaknesses increase risk?
Strength deficits are definitely significant. Weakness in the rotator cuff, especially measured isometrically or isokinetically for external rotation strength, is a well-established risk factor. The cuff muscles are vital for dynamic stability and controlling those high forces.
Are there gender differences here?
There appear to be, yes. So do studies, for instance in handball, found isometric external and internal rotation strength deficits were linked to injury risk, specifically in females, whereas obvious scapular dyskinesis during abduction was more strongly linked to injury risk in males in the same sport.
And what about weakness further down the kinetic chain?
Hugely important and often overlooked in purely shoulder-focused screens. Kinetic chain weakness is critical. For example, having asymmetry in hip abductor strength, maybe the lead leg being significantly stronger than the trail leg, has been linked to increased injury risk. General core weakness or poor core endurance also contribute significantly.
Because the shoulder and arm have to compensate.
Precisely. If the core and lower body aren't efficiently generating and transferring energy, the shoulder girdle muscles are forced to overwork, leading to fatigue, altered mechanics, and ultimately injury.
Makes perfect sense. What about training load? How much or how intensely someone trains factor in?
Training load is a major modifiable risk factor. The concept of the acute to chronic workload ratio, ACWR, is really valuable here. Rapid spikes in training load, the acute load, compared to what the athlete is accustomed to their chronic load, significantly increase injury risk.
So, doing too much too soon.
Essentially, yes. For instance, studies in handball have shown that more than a 60% increase in weekly load compared to the previous month's average is a significant risk factor. Gradual, planned progression of volume and intensity is crucial to allow tissues to adapt.
Okay. And what about just having had pain before?
That's arguably one of the strongest and most consistent predictors. A history of previous pain or injury in the shoulder or elbow.
Yeah.
Even if it seemed minor at the time, it significantly increases the risk of a future, potentially more severe, injury. It highlights why taking a thorough history is so important and why we need to address even seemingly minor complaints properly.
Are there factors athletes can't really change? Non-modifiable risks?
Yes, several. Playing position is a big one. As we've discussed, pitchers in baseball, backcourt players in handball, potentially quarterbacks, catchers, their roles inherently involve higher risk due to the specific demands. Gender shows moderate evidence with those specific associations we mentioned. And age generally correlates with increased injury prevalence, likely due to cumulative wear, slower tissue healing, and perhaps age-related changes in tissue properties.
We touched on scapular dyskinesis and the debate around it. What's the clinical take-home message regarding its role as a risk factor?
The evidence is still evolving, making it a bit controversial. Yes, it's often seen with injuries, but it's also common in asymptomatic athletes. So is it a cause, an effect, or an adaptation? The jury is still somewhat out on its definitive causal role for all cases.
Yeah.
However, the consensus generally remains that obvious, marked dyskinesis is still considered a risk factor worth addressing, as it likely signifies some underlying neuromuscular control issue or muscle imbalance.
And injury risk in competition versus practice, is one setting riskier?
Historically, the evidence was conflicting. But more recent, better quality studies seem to be showing that the rate of acute, significant time loss injuries tends to be higher during competition. This likely reflects the higher intensity, maximal effort, and perhaps increased contact or unexpected movements in games.
But practice injuries still matter.
Absolutely. We shouldn't ignore the burden of non-time loss injuries or overuse issues that develop during practice. These can accumulate and eventually lead to more significant problems or decreased performance if not managed appropriately. Both settings require attention to load management and technique.
So putting this all together, what are the limitations of just relying on preseason screening tests like ROM measurements to predict injury?
The main limitation is that no single test, or even a small battery of tests, is perfectly predictive across all individuals in all sports. While screening for factors like GRAD, rotator cuff strength, or core endurance is valuable, the overall evidence for consistent predictive power of generic screens across diverse overhead athlete populations is limited. Meaning, we need a more holistic and individualized approach. Screening results must be interpreted in the context of the athlete's specific sport, their position, their competition level, their age, and critically, their individual history of pain and previous injuries. A comprehensive assessment beats relying on any single number.
That's a really important point about context. Okay, let's move towards solutions. How are modern diagnostics and proactive prevention strategies evolving? Starting with throwing analysis, what can biomechanical assessments tell us now?
Modern biomechanical throwing analysis is becoming increasingly sophisticated and accessible. The gold standard often involves video motion capture, using multiple high-speed cameras in a lab setting. This captures the throw in 3D with incredible detail.
And what do you do with that data?
We analyze it to calculate specific key performance indicators (KPIs). These aren't just about performance like ball speed, but critically about how that performance is achieved biomechanically. We look at joint angles, velocities, torque throughout the entire throwing motion.
Can you give some examples of key KPIs you'd look at?
Sure. Beyond ball speed, we look closely at maximum shoulder external rotation, MER, achieved during cocking. Also, the elbow angle at MER. Critically, we calculate the maximum elbow varus torque, which quantifies that stress on the UCL we discussed. We look at hip-shoulder separation at foot contact, a measure of how well they use their trunk rotation and core to generate power. And things like knee flexion angle at ball release, which tells us about their lower limb contribution and stability.
And how do you use these KPIs?
We compare the athlete's individual results against established norms for their age group and competition-level youth, high school, collegiate, professional. This allows us to identify subtle deviations from efficient and safe mechanics, deviations that might increase their injury risk, often before they even develop symptoms.
That sounds powerful. You also mentioned a new frontier with markerless technology. What's the potential there?
This is really exciting. Markerless motion capture systems are emerging that don't require the athlete to wear reflective markers, making them much easier to use outside of a dedicated lab.
Oh.
Systems like Hawkeye StatCast are already used in professional baseball parks.
Capturing data during actual games.
Exactly. Using multiple cameras around the stadium, they can track pitcher mechanics, ball release point, spin rate, velocity, and much more, all during live competition. Other systems like Kinetrax, Simi, Thea 3D, Dario Motion are also being developed for various applications, offering 3D kinematic data without markers.
What are the benefits?
The potential is huge for providing real-time feedback, tracking fatigue-related changes in mechanics during a game or practice, and gathering large data sets to better understand links between mechanics, performance, and injury risk in real-world conditions. While the validation against traditional marker-based systems is still ongoing in peer-reviewed literature for some applications, the potential for accessible in-game analysis is a massive step forward for both performance optimization and injury prevention.
Definitely one to watch. So beyond diagnostics, what about prevention programs themselves? What does an evidence-based program for overhead athletes typically involve?
The research increasingly shows that well-structured intervention programs can make a real difference in reducing shoulder and elbow problems. The most effective programs tend to be multifaceted.
Targeting what specifically?
They typically focus on improving key areas identified as risk factors. So exercises to improve glenohumeral internal rotation ROM, addressing GRD, specific strengthening for the rotator cuff and scapular stabilizer muscles, exercises to enhance kinetic chain function, core stability, hip strength, leg power transfer, and improving thoracic spine mobility, which is crucial for optimal shoulder function.
So it's a whole body approach.
Absolutely, not just isolated shoulder exercises. Successful programs often incorporate dynamic mobility drills for the scapula and thoracic spine, specific stretches like the sleeper stretch, strengthening exercises for the cuff and scapular muscles, and crucially, exercises targeting the lower extremities and core for balance, power, and stability.
And is it a one-size-fits-all program?
Definitely not. The evidence points towards a drilling down approach. Prevention needs to be tailored to the specific demands of the sport, tailored to the specific position within that sport, and potentially even tailored based on individual screening results. A pitcher's program will look different from a swimmer's or a tennis player's.
What else is key in prevention?
Beyond exercises, Critical elements include educating athletes to recognize and report early signs of pain or dysfunction, ensuring adequate rest and recovery periods are built into training schedules, and particularly in sports like baseball, meticulously managing throwing load pitch counts, innings limits, intensity variations. Interrupting that cycle of cumulative overload is paramount.
That makes complete sense. Right, let's transition now to guiding recovery after an injury has occurred. What are the foundational principles for treatment and rehabilitation? Where do clinicians typically start?
The cornerstone, especially for many overuse type injuries like tendinopathies or what used to be called impingement syndrome, is that conservative management should almost always be the first line of approach.
Meaning non-surgical.
Yes. As we discussed, symptoms often relate more to tissue sensitivity and an imbalance between load and capacity rather than necessarily irreversible structural damage.
Yeah.
So the initial steps are usually straightforward. Rest from the aggravating activity, sometimes complete rest initially, sometimes relative rest. Pain relief is important too, often using NSAIDs in the acute phase and applying ice packs to manage pain and any inflammation.
Okay, calm things down first, then what? What does the actual rehab journey look like? Is it structured?
Yes, a structured, phased rehabilitation program is absolutely essential. The goal is to progressively and safely restore full function, range of motion, strength, stability, neuromuscular control, and minimize the risk of re-injury upon return to sport. We typically think in terms of four main phases.
Okay, phase I.
Phase 1 is the acute phase. The immediate goals here are to reduce pain and inflammation, start normalizing any significant loss of range of motion gently, begin reestablishing basic muscular balance around the joint, and try to delay muscle atrophy from disuse. Treatments might involve continued icing, possibly some electrotherapy modalities for pain relief, gentle passive or active assisted flexibility exercises, very low level, often isometric, strengthening for the rotator cuff and scapular muscles, and maybe some basic balance or proprioceptive exercises.
Protecting the area while keeping things moving gently. What happens in phase 2?
Phase 2 is the intermediate phase. Here, the goals become more active. We aim to progressively increase strengthening exercises, really work on restoring muscular balance across agonist-antagonist pairs, start augmenting dynamic stability of the joint, achieve full pain-free range of motion, and really optimize neuromuscular control.
What kinds of treatments or exercises are typical here?
We'd continue with stretching and flexibility work as needed. Strengthening progresses from isometrics to isotonic exercises, using resistance bands, light weights, or cables, gradually increasing the load and complexity. We might introduce rhythmic stabilization drills, where the therapist provides perturbations for the athlete to resist, enhancing dynamic joint control.
Getting stronger and more controlled. What's phase 3?
Phase 3 is the advanced strengthening phase. The focus now shifts towards increasing strength and endurance in ways that are more specific to the demands of their sport. We're really pushing neuromuscular control under higher loads and speeds. This is where programs like the Advanced Throwers 10 might come in, incorporating more challenging exercises. We continue with sport-specific drills, building the capacity needed for performance.
And the final hurdle, phase 4, getting back to the sport itself.
Exactly. Phase 4 is the return to activity phase, or return to throwing sport. This is arguably the most critical and challenging phase to manage correctly. The goal is to implement a very progressive, carefully monitored, sport-specific program. The athlete needs to demonstrate full strength, be completely pain-free during and after activity, and show excellent neuromuscular control, proprioception, flexibility, and strength throughout the entire kinetic chain.
What factors guide this phase?
It's highly individualized. Key considerations include the athlete's age, their specific competition level, their playing position, and the expected volume and intensity of activity upon return. For example, managing the number of throws, serves, or hits per session or week is crucial. We need to ensure they can tolerate the demands without symptom recurrence. Programs like the Throwers 10, especially the advanced version, provide a good framework of exercises focusing on that neuromuscular control, strength, coordination, and muscular balance needed for the transition back to full training and competition.
That's a very clear structure. To make it even more tangible for clinicians listening, could you give some specific examples of the types of exercises commonly used within these phases, perhaps drawing from some of the sources?
Certainly. Let's break it down by target area. For rotator cuff strengthening, cornerstone exercises are external rotation and internal rotation. These start isometrically just holding against resistance, which is great early on, then progress to using resistance bands or cables, ensuring good form and control through the range.
Okay. What about exercises for lifting the arm, like abduction?
For shoulder abduction, lateral raises are common. These can be done with bands, cables, or light dumbbells. Performing them in the scapular plane, which is about 30–45 degrees forward from the frontal plane, often feels more comfortable and natural for the shoulder joint. Again, isometrics, like pushing the arm outwards against a wall, can be a good starting point or variation.
And strengthening the muscles around the shoulder blade and upper back, crucial for stability.
Absolutely. For the back of shoulders and upper back, exercises often progress from having the arms by the side towards overhead movements. The classic A's, T's, and Y's are examples, named for the arm positions. These target the rhomboids, middle and lower trapezius, and posterior deltoids. They can be done prone over an inclined bench, standing using bands or cables, or even isometrically on the ground. Prone angels, or swimmers, are other good options for promoting controlled movement and endurance in these key scapular stabilizers.
What about exercises that integrate the shoulder with the rest of the body, particularly weight-bearing?
Weight-bearing and scapular stability exercises are vital. The standard plank is a great example, on hands or forearms. The key cue is often to actively push the floor away, promoting scapular protraction and engaging serratus anterior. You can modify difficulty easily, knees down, long lever, adding movement like shoulder taps to challenge stability further. For compound pushing-pulling, things like push-ups, modified as needed, example on knees or incline, inverted rows or TRX rows are excellent. Horizontal pushing and pulling generally places less stress on the shoulder joint than vertical movements, making them good choices, especially earlier in rehab.
And finally, if someone has lost overhead range of motion, perhaps due to stiffness, how do you address that?
To improve overhead range of motion, ROM, especially shoulder flexion, exercises like supine shoulder flexion with a dowel are common. Lying on the back helps stabilize the trunk, and the athlete uses the dowel, or their other arm, to gently guide the affected arm overhead within a pain-free range. Gentle rocking movements against a wall or elevated surface, or pullover variations with a light weight, can also help mobilize the shoulder into flexion and encourage necessary thoracic extension, which often limits full overhead reach.
That provides a really practical toolkit. Beyond the specific exercises, what are the overarching principles that should guide a clinician and the patient through this whole rehab process?
Several key principles stand out. Firstly, consistency is absolutely key. Patients need to understand that doing something regularly, even if it's just a few key exercises, is far better than sporadic, intense sessions. Something is better than nothing is a good mantra.
Okay, consistency. What else?
Gradual progression. You have to respect tissue healing times and physiological adaptation. Load needs to increase slowly and progressively over time. Trying to do too much too soon is a classic cause of setbacks.
Makes sense.
Also, tolerability. Exercises should generally be performed within a tolerable range of discomfort. Significant pain during or after exercise is usually assigned to modify the exercise, reduce the load, or temporarily regress. Pain is a signal, not something to just push through relentlessly.
Listen to your body.
Exactly. Interestingly, research also suggests that sometimes more isn't necessarily better. We don't always need a huge list of exercises. Sometimes just one or two well-chosen exercises performed consistently can significantly improve symptoms. And finally, managing expectations regarding time frame. Clinicians need to educate patients that meaningful recovery, especially after surgery or for chronic issues, often takes at least 3 months and frequently much longer. Patience and persistence are non-negotiable.
Really important points on managing the process. Now, the final stage, the return to play decision. This feels incredibly complex, balancing the athlete's desire to return with the risk of re-injury. How do clinicians navigate this? Are there gold standards?
It is highly complex and multifactorial, and honestly, there isn't one single gold standard test that gives a definitive green light. The overriding priority is always to minimize the risk of re-injury, which can have devastating consequences.
So what do you rely on?
In the absence of a universally agreed magic bullet test, clinicians generally rely on a combination of factors. We use general guidelines, often based on expert consensus and clinical experience, regarding expected cutoff values for things like regaining full pain-free range of motion, achieving symmetrical strength compared to the uninjured side, often aiming for 90%, and demonstrating good functional capacity, for example, achieving certain throwing velocities or hitting power without pain or mechanical compensations.
But it's more than just hitting numbers.
Oh, absolutely. Those objective measures must be considered alongside the individual athlete's context, their specific sport, position, level of competition, their psychological readiness to return, and their tolerance for risk. A crucial part of the decision is also ensuring a well-structured load management plan is in place for their return to training and competition to avoid immediately overloading the newly healed tissues.
And postoperative rehab has specific return to play criteria.
Yes, for postoperative cases, specific criteria often include demonstrating the restoration of normal scapulohumeral rhythm, showing excellent trunk and core stability, having regained full elbow ROM and strength, if relevant, and exhibiting good balance and proprioception before even starting the final stages of sport-specific drills like an interval throwing program. It's about ensuring the entire kinetic chain is functioning optimally, not just the surgical site.
It's clearly a nuanced decision requiring careful clinical judgment. Okay, this has been incredibly detailed. Let's try and ground some of this in a specific context using that fascinating case study on volleyball injuries. Why is looking at age-specific data in a sport like volleyball so valuable for us as clinicians?
This analysis of national U.S. volleyball injury data over nearly a decade is incredibly valuable because it moves beyond generic volleyball injury statistics. By breaking down the data by adult age groups, it reveals distinct patterns in how and why injuries occur at different stages of life. This provides much more targeted insights for prevention and management than just looking at the overall averages.
The study covered a wide age range, didn't it?
It did. The mean age of injured players was about 36, but the range was huge from 19 right up to 79 years old. This allowed for really interesting comparisons between younger adult players and older adult players.
So what were the big picture trends? Across all adults, what were the most common injuries and body parts affected in volleyball?
Overall, the most frequently injured body parts were fingers, making up about a third of injuries, 33.2%, likely from blocking or setting. Shoulders were second, at nearly 29%, reflecting the overhead demands of spiking and serving, and wrists accounted for 16%. In terms of diagnosis, sprains and strains were the most common, 33.5%, followed by fractures, 19.6%, and dislocations, 19.1%.
Okay, that gives us the general landscape, but the really interesting part was how the mechanisms of injury differed by age, wasn't it?
Precisely. This is where the practical insights emerge. Overall, the most common ways people got injured were impacts with the floor, 24%, impacts with the ball, 18.7%, and injuries specifically during spikes or serves, 6.9%. But these proportions shifted dramatically when looking at different age groups.
Let's start with the younger adults, say the 20 to 39-year-olds. What characterized their injuries?
This younger group, likely playing at a higher intensity, showed the highest rate of shoulder dislocations. They accounted for 37% of all shoulder dislocations in the data set. Crucially, they also had the highest rates of injuries directly resulting from those dynamic, powerful movements. Spikes and serves caused 8.2% of their injuries.
And were the dislocations linked to those movements?
Yes, significantly. A striking 43% of the shoulder dislocations in this 20-39 age group occurred during a spike or serve. It really points towards injuries happening at the peak of athletic exertion and force generation in this cohort.
That paints a clear picture. Now, contrast that with the older adults, the 60-plus age group. What did their injury profile look like? I imagine it was quite different.
Very different indeed, reflecting the physiological changes associated with aging. This 60-plus group had the highest rates of sprains and strains, 41.1% of their injuries, suggesting perhaps reduced tissue resilience or tolerance to load. But most strikingly, they suffered the highest rates of injuries resulting from direct trauma rather than dynamic sporting movements.
Trauma like falls.
Exactly. Injuries from impacts on the floor accounted for 37.7% of their injuries, and impacts with the ball for 23.4%. To illustrate, this older group accounted for nearly 14% of all shoulder dislocations and over 25% of all wrist fractures in the entire study.
And you mentioned something specific about those wrist fractures in the 60-plus group.
Yes, this was a standout finding. Of all the estimated wrist fractures in the 60-plus age group, an incredible 100% were attributed to impacts with the floor. This strongly suggests Fuchs injuries falling on an outstretched hand.
Can you quickly explain the Fuchs mechanism again and why it's so problematic?
Certainly. Our arms are generally designed for open chain movements, where the hand moves freely. When you fall onto an outstretched hand, it becomes a closed chain situation. The hand is fixed on the ground. This transmits large compressive and shear forces directly up the arm through the wrist, elbow, and shoulder joints. The structures aren't ideally designed for that kind of loading, leading to a high risk of fractures, ligament tears, or dislocations. The high rate of Fuchs-related wrist fractures and shoulder dislocations in the older group likely reflects this mechanism combined with age-related factors.
Which age-related factors specifically make older adults more vulnerable to these types of traumatic injuries?
Several factors contribute. There's often a natural decrease in bone density, osteopenia or osteoporosis, making fractures more likely from a fall. We also tend to see impaired coordination, balance, and fine motor skills with age, increasing the risk of falling in the first place. Biologically, there can be accelerated ligament degeneration due to changes in collagen, perhaps reduced protein synthesis, maybe lower vitamin D levels, all contributing to reduced structural durability of tissues. This makes joints more susceptible to dislocations or soft tissue injuries like bursitis or tendinitis, even from relatively lower impact forces.
So the clear implication for clinicians and coaches working with volleyball players is
That prevention strategies really need to be age-specific. Generic advice about fitness, hydration, warm-ups, and protective gear, while important, isn't enough. For older adult players, prevention should likely place a much stronger emphasis on interventions targeting balance, coordination, and specific strengthening exercises to reduce fall risk. Perhaps even considering bone health screening and management, like advising on calcium and vitamin D intake or appropriate exercise for bone density. It's about tailoring the approach to the specific vulnerabilities of the demographic.
moving towards truly personalized injury prevention based on age profile. Before we leave the case study, were there any significant gender differences noted in the volleyball injuries?
Yes, there were some notable differences. Female patients in the study had significantly higher rates of sprains and strains, making up nearly 40% of their injuries, and also accounted for the majority of contusions and abrasions, over 67% of the total. Male patients, conversely, had significantly higher rates of dislocations, over 31% of their injuries.
Interesting. Suggesting perhaps different biomechanics, playing styles, or physiological factors might be at play between genders as well.
Potentially, yes.
Mm.
It suggests that prevention and even diagnostic approaches might benefit from considering gender-specific patterns alongside age and playing level.
This whole deep dive has been incredibly comprehensive. As we bring it towards a close, reflecting on everything we've discussed, the biomechanics, the risks, the rehab, the age-specific factors, what stands out to you as the most crucial takeaway for our listeners managing these overhead athletes?
For me, it really solidifies the absolute necessity of thinking holistically and interconnectedly. You simply cannot manage these complex overhead injuries effectively by just looking at the painful joint in isolation. Understanding the entire kinetic chain from the ground up is paramount. Identifying those subtle but critical risk factors, whether it's GIRD, rotator cuff weakness, core instability, poor landing mechanics, or those age-related vulnerabilities we saw in the volleyball study, that's where effective prevention and targeted rehab begins. It reinforces that tailored, specific programs tailored to the sport, the position, the individual, the age, are essential for truly successful outcomes and getting athletes back performing at their best safely and sustainably.
A powerful summary. And for you, our listeners, we sincerely hope this deep dive has equipped you with valuable, actionable insights you can integrate directly into your clinical practice, helping you better support the overhead athletes under your care. If you found this deep dive valuable, please do take just a moment to rate and share our show. It genuinely helps us reach more practitioners like you.
In a world where athletic performance relentlessly pushes the boundaries of human physiology, perhaps the ultimate challenge for us as medical professionals isn't merely to repair the damage after it occurs. Maybe it's to truly understand and then proactively reinforce that incredibly delicate balance between the immense forces these athletes generate and the body's remarkable but ultimately finite capacity for adaptation. It's about empowering resilience, not just recovery.